Welcome, everybody, to the September podcast. Welcome to Capri Hospital. I'm Siali Foliaki and I'm a psychiatrist. And looking forward to presenting some information today about benzodiazepines, the growing use of quetiapine in primary and in secondary care and within the hospital system. And setting the scene for a discussion in next month's podcast about the treatment of anxiety disorders, with a particular reference to the wide range of SSRIs that now are commonly used in primary care and throughout the health system. And just a little bit of a discussion about the differences between those various SSRIs and when you would use one over another. So hope that you're going to find today informative, or this particular podcast informative, and hopefully we can set the scene also for next month's podcast. The critical question that I would like to ask all of us as medical practitioners, if you're going to start a benzodiazepine, when are you going to stop it? So for whatever reason that you might choose to start one, whether it's for a sleep disturbance, whether it's for treating a panic disorder, anxiety, whether it's a period of distress, the question we've got to ask is, we're going to start this medication, when are we going to stop it? The reason that we've got to ask this question, because we're just seeing far too many people still that are coming in to our setting here at Capri Hospital with really significant benzodiazepine dependency. And that dependency has been built not over months but over years. And so we're getting people here that have got a benzodiazepine dependency, that have been on benzodiazepines for many years, and they have to be getting those benzodiazepines from somewhere. The biggest challenge is then getting them off. One of the real long-term side effects of the benzodiazepines is I think that it really affects that part of the brain that controls our capacity to have mental fortitude or our willpower. And so it also sets up the brain to be kind of far more hyper-anxious after a period of usage. And so what does that mean? It means that we make our patients more anxious. And that, yes, and during the initial stages they might be really beneficial, but it's really problematic. So I just want to talk a little bit about specific actions of the benzodiazepines. One thing that I want to draw to everybody's attention is the really long half-life of diazepam. So depending on which sort of pharmacological textbook you read, the benzodiazepines, diazepam in particular, has a really long half-life. The half-life is actually incredibly long, and so somewhere up to between 50 and up to potentially 100 hours is the half-life, which means that this particular drug, it sits around in people's system for an incredibly long period of time. Once you start using it and some dependency starts to develop, the amount of diazepam that people take can go up quite rapidly. And then coming off the benzodiazepines, it looks like initially you can have some success. You can get them down off 80, 60, 40 milligrams down to 15, 10 quite easily because of its long half-life. The real problems is when you try to get them off that final bit. And what do you do in terms of the rebound anxiety that people tend to experience when they're coming off the benzodiazepines? That's where a medication like quetiapine is really, really valuable. Now, quetiapine seems to be used in greater amounts in primary care, and I think it's a really fantastic drug. It was first used or marketed as an antipsychotic, but really its antipsychotic properties don't really kick in until you get into higher doses. What do I mean by higher doses? 300 milligrams or over for quetiapine. So anything less than 300 milligrams, it acts like an anti-anxiety agent. Why it's particularly useful is because, again, of its own half-life. Now, quetiapine has a half-life of somewhere between 12 and 18 hours. That means you can give it at night time, say at 8 o'clock or 9 o'clock before somebody goes to sleep. The sedating effects are quite helpful. It's not a sedative, but its anti-anxiety properties combined with being tired normally means that people get a reasonable night's sleep on quetiapine. 12 hours later, 50% of the quetiapine is still present in the system, and it works over the course of the day, giving good anti-anxiety relief. So increasing doses of quetiapine in relation to perhaps helping somebody come off diazepam is a really good idea. But I'd like people in primary care, doctors in primary care, to consider when somebody's distressed, acutely distressed, a very short course of diazepam in conjunction with a medication like quetiapine that takes a little bit longer to kick in isn't as effective. But as you pull the diazepam, if you want to manage somebody's anxiety or distress in the short term, over a few days, fantastic to use the benzos. But then quetiapine is an adjunct that when you pull the benzos, they can stay on that quetiapine. So that combination of medications, I think, is really, really valuable and really, really helpful, even in acute distress. Use the benzos first, a bit of cover with quetiapine, and after sort of 7, 10, 14 days, there's no risk of dependency for the benzodiazepines. You can start to pull the benzodiazepines and use quetiapine if you need to have sort of medium-term control of distress or significant anxiety. The take-home message that I'm giving you today is, in any context where you want to use the benzodiazepines, if you use it in conjunction with quetiapine and quetiapine sits in behind the benzodiazepine, not only together will you get better sort of consistent relief over 24-hour coverage, together you'll enhance the effects of the benzodiazepines, and the benzodiazepines will actually, I don't know if it'll enhance the quetiapine, but it will certainly allow the quetiapine time to take effect and provide better anxiety relief or distress relief. But then you've got a window that allows you to then withdraw the benzodiazepines if you still feel like the distress or the emotional discomfort that's being experienced, or perhaps the anxiety that needs treating. You're not going to pull the benzodiazepine away completely and leave somebody emotionally distressed as a result of pulling back on the benzodiazepines. And ultimately, that protects that person from developing the benzodiazepine dependency, which I think is really, really debilitating and is causing a lot of morbidity in our community because of the inappropriate usage of the benzodiazepines. So this combination of benzodiazepines and quetiapine, kind of leads me on to the discussion of anxiety and the treatment of anxiety. And I do want to think very carefully about the information about anxiety and the pharmacology of anxiety, starting with the SSRIs. We know that there are a range of SSRIs now, and so the licensed SSRIs, starting with fluoxetine, paroxetine, citalopram, sertraline, there are a number. And all of them are indicated for the treatment of anxiety, alongside medications like the benzodiazepines and quetiapine. And we know that there are different anxiety disorders where a different SSRI has evidence that it's more effective than another. So if you're treating obsessive compulsive disorder versus post-traumatic stress disorder, generalized anxiety, or panic disorder, then the literature suggests that slightly different SSRIs are actually more effective. And essentially that's what I would like to talk about in our upcoming podcast. In the acute setting where somebody's really distressed, the SSRIs are not overly effective. But if that distress is related to an underlying anxiety disorder, I think it's really, really important that we consider putting somebody on an SSRI. But like I've spoken about already, the benzodiazepines are really, really effective. And so if somebody comes into you and they're having panic attacks, and those panic attacks are relatively frequent, or they seem to be worsening, there's absolutely it's a compassionate thing to do to give them some benzodiazepines. It's the thing that would probably be most effective at halting those panic attacks. Like I said, if you add a little bit of quetiapine, then what happens is you get a chance to create a window for the benzodiazepines to work, and then you can withdraw them. But if you're dealing with panic disorder, then clearly an SSRI is indicated, and the discussion we need to have is about which SSRI would be the most effective in panic disorder. But one of the things that we've decided as a team here at Capri is we want to keep our podcasts short. We want to jam in a reasonable amount of information so that if you do take the time to sit and watch the podcast, that it gives you a reasonable amount of information that's hopefully well communicated, so it's not too disjointed. But it also would like to be able to set up a podcast this month that leads into the podcast next month, so you get a sense for the direction that we're taking it, and each podcast is linked. So I think I've given sufficient information today about the benzodiazepines, about quetiapine, and what we're going to lead into, which is the treatment of anxiety disorders with an initial focus on SSRIs and which SSRI is most pertinent in which particular clinical situation, which is what we're going to discuss next time, particularly with reference to an ongoing discussion that I think primary care doctors could start to integrate into their practice. And that is, how do we make some judgments about the character or the personality of the person sitting in front of us, to be able to do that in a fairly evidence-based way so that we can make some decisions around pharmacology. Because I'd like to end on this note. There's really good evidence that if somebody has a dependent personality style, or an access to problem like a dependent personality disorder, then they have a high disposition towards developing a dependency on pharmacological agents like the benzodiazepines. So one of the things we have to do is we have to get our pharmacology right, but I also think that we need to take into consideration the fabric of the person that's sitting in front of us and have some framework in our mind to make some judgments as to the type of personality that you think that they might have. And to be honest, that's a far more interesting conversation than the one about pharmacology, but I think both things are really important if we're going to try to provide the best quality of care that we can for our patients. Thanks for listening, and check in next time.